Phimosis in under 5 minutes. A short tutorial for Discover Pediatric Surgery by Karen Milford, Andrew Grieve and Nirav Patel. Some useful terms to know. The glans is the head of the penis, concealed by a phimotic foreskin. The inner prepuce is the inside foreskin, not visible in the phimotic state. The outer prepuce is the outer part of the foreskin, which covers the head of the penis. Phimosis is when the foreskin or the prepuce is closed over the glans and cannot be retracted. Phimosis is normal at birth and extends into childhood. By the age of 5, around 50% of patients with phimosis have spontaneously retractile foreskins. By the age of 17, this increases to 99%. Phimosis is no longer physiological and becomes pathological when certain things occur. This includes recurrent infection of the foreskin or glans, scarring of the foreskin, which typically begins to appear pale, with radial scarring pointing downwards and outwards from the phimotic ring, and ballooning of the prepuce due to urine trapped underneath the foreskin. Pathological or symptomatic phimosis can be managed conservatively, medically, or surgically. Conservative management consists of gentle retraction of the foreskin, usually in the bath at night. Parents should take care not to retract the foreskin so much that there is bleeding, as this will cause scarring and trauma and worsen the phimosis. Medical therapy in the form of low-dose steroid creams is another treatment option. In this case, steroid cream can be applied to the phimotic ring twice a day for up to 2 weeks at a time. This treatment helps to soften the phimotic ring and should be accompanied by gentle retraction of the foreskin, again taking care to avoid cracking and bleeding. Once the course of steroid cream is complete, the family should be advised to apply Vaseline instead in order to decrease the risk of recurrence. There are 2 surgical options for management of phimosis. The first is circumcision, where the prepuce is removed in its entirety. In this case, the likelihood of recurrent phimosis is extremely low. A small number of boys may develop a post-circumcision cicatrix that may mimic phimosis and will require surgical revision. In those patients that prefer to preserve the foreskin, prepucioplasty is an option. In this technique, a series of Z-plasties around the phimotic ring open the phimotic ring. Prepucioplasty is associated with an increased risk of recurrence, and this is especially so if the glans is not protected with barrier cream postoperatively and the foreskin is not diligently retracted. The most serious form of phimosis is BXO, or balanitis xerotica obliterans. BXO refers to a patchy, scaly scarring of the phimotic foreskin that can extend into the glans and the urethra and is considered an absolute indication for circumcision. In general, asymptomatic phimosis should be managed conservatively. For those patients with symptomatic phimosis, surgery is not the only management option. Rather, management decisions must be based on the patient's age, symptomatology, and the treatment preferences of the patients and their families after discussing the risks and benefits of all 3 treatment modalities. In those patients that do undergo surgical management, postoperative care is uncomplicated. Parents should be counseled on the appropriate administration of analgesia and wound care, including the application of a topical antibiotic 2 to 3 times per day for 3 to 4 days postoperatively. Should parents notice any danger signs including excessive bleeding, swelling, pain, or a foul-smelling discharge from the wound, they should return immediately for their child to be reviewed. Thanks for listening, and please visit the Surgeons for Little Lives website or the Discover Pediatric Surgery channel on YouTube to download and share this and similar tutorials for free.